Thank you all for tuning in to what will hopefully be a wonderful morning into early afternoon of education on the latest and greatest in multiple myeloma. Joined today by an esteemed group of myeloma faculty from around the North America landscape. We have Dr. Keith Stewart, Dr. Gareth Morgan, Dr. Nikhil Munshi, Dr. Saad Usmani, from some of the most prestigious myeloma programs that exist. And they are going to walk you through the current and emerging treatment options for multiple myeloma. This is an accredited event. There will be forms to complete at the end for CME credit. You can receive up to 3 AMA PRA Category 1 credits, so please make sure that at the completion of today's webinar, you complete this to ensure that you receive the proper credit for attending and participating. Again, you must attend the webinar completely, after which you'll be able to download a brief evaluation and then the certificate links at the end of the conclusion of the program. Here are our learning objectives for today's event. We're going to outline the classification and treatment of smoldering multiple myeloma, the benefits and risks of various approaches to frontline treatment for newly diagnosed disease, the role of sequencing therapies in the relapsed and refractory landscape, then moving on to some of the more novel approaches such as the BCMA targeted agents such as CAR-Ts, bispecific antibodies, and antibody drug conjugates. We have our list of speakers today, starting off with Dr. Keith Stewart, who's going to take us through the overview and classification and treatment of smoldering multiple myeloma before we move through frontline with Dr. Gareth Morgan, relapse and refractory setting with Dr. Usmani, the BCMA CAR-Ts with Dr. Nikhil Munshi, and I will round out things with the bispecifics and antibody drug conjugates. With that, I'd like to turn it over to the amazing Dr. Keith Stewart. Please, sir.
Thank you, Josh, and good morning, everybody. We're going to start our discussion of smoldering myeloma with the pre-test clinical vignette. So today's case is a 70-year-old woman who was originally referred due to the incidental finding of a monoclonal protein during a workup by her family doctor for sensory peripheral neuropathy. She is otherwise well, healthy, and recently retired. Her hemoglobin was 11.8 grams per deciliter. White blood cell count, platelets, creatinine, and calcium were all normal. IgG was 2,700, M-spike of 1.82. Serum free light chain ratio was 18, and her urine protein was negative. People need, so I'm getting a bit of echo here. The bone marrow showed 8% restricted plasma cells. Sorry, I think somebody has to mute because I'm getting a lot of feedback. Let's try that again. So bone marrow showed 8% lambda-restricted plasma cells in the aspirate, 25% plasma cells in biopsy. So certainly has criteria for myeloma on the biopsy. Cytogenetic showed translocation 1114, but a PET scan was negative. You decided on observation. 6 months later, however, her M protein was slightly higher at 2.4. Serum free light chain ratio was slightly higher at 47. Other labs were essentially unchanged, and you determined that she now has high-risk smoldering myeloma. You advise one of the following 5 options: a new bone marrow with repeat PET scan and 24-hour urine protein now, lenalidomide because trials show increased overall survival, referral to a possible clinical trial at a local university hospital if the patient is interested. You will start datatuzumab, lenalidomide, and dexamethasone because of the long progression-free survival. Or you will advise against any therapy since progression-free survival is not improved by early intervention. So please go ahead and vote. We will revisit this question at the end of the presentation. Sorry, was there a way to see the responses, or that comes at the end? I guess it comes at the end. Okay, so smoldering myeloma for many years was not particularly interesting, except as a category of disease that we would watch carefully. But over the past 5 years, there's been a significant amount of work performed in this area as treatments have become more effective, and the question has risen as to whether one can intercept and prevent serious disease through early treatment. These are my conflicts of interest. So just to remind everybody that we're all on the same page, so MGUS, generally a small M spike, less than 3 grams per deciliter, less than 10% bone marrow plasma cells, and absent a myeloma-defining event. Symptomatic myeloma, of course, being the presence of monoclonal protein, more than 10% plasma cells in the bone marrow, and a myeloma-defining event, and smoldering myeloma being in the middle, with over 10% plasma cells in the marrow, or a high serum protein, and no myeloma-defining events. So it turns out, as technology is evolving, I wanted to mention that while we're used to quoting a 3% risk of MGUS in an elderly population, or perhaps even less, it is clear that with more sensitive technologies, that the presence of a monoclonal protein is actually quite high. I'm just going to quote one slide from Irene Gabriel from Dana-Farber Research Institute, who took some patients over age 50 who actually had, from the Biobank of Massachusetts General Hospital, who either in the general population over 50, she found 3% of patients had MGUS by traditional technology. She took a slightly higher risk population. These were patients who had a family history or some comorbidity and or were African American, and demonstrated that by traditional plasma protein electrophoresis or immunofixation, up to 6% of that population had a monoclonal protein. But the real reason to show you this slide is that when mass spectrometry was applied, that was almost doubled due to the increased sensitivity of the testing. Now, next year, we expect mass spectrometry testing to become more freely available through the binding site company. And it's clear that with that test, if it was used widely, we're going to see a much larger percentage of patients with a detectable monoclonal protein in their blood to start with. Now, Irene went on to show, I think quite interestingly, that it's not only associated with myeloma, but in this analysis of all the comorbidities of patients with monoclonal proteins, you'll see in red at the bottom of the slide, of course, there's an increased risk of chronic lymphocytic leukemia, Hodgkin's lymphoma, non-Hodgkin's lymphoma, and as well as myeloma. But also above, we see an increased association with coronary artery disease, myocardial infarction, lupus, rheumatoid arthritis, and other autoimmune diseases. And what Irene has shown quite interestingly, if you look here at the far, I'll use a pointer here. If you look here at the far left of the slide, you'll see that overall, patients over the age of 50 with a monoclonal protein have a worse overall survival, and this changes with age. At less than 50, it's not apparent. Between 50 and 65, it becomes apparent, and once you're over 65, there's a fairly significant decline in overall survival just because you detected a monoclonal protein, which is probably an indicator of some other problem underlying. So there is some significance to finding a monoclonal protein, even in a generally healthy population. Now, I wanted to talk about the Icelandic study of called iStop. This is a very ambitious program in Iceland where 75,000 of the 300,000 people who live there had a screening for monoclonal proteins. They found that, as you would expect, the 3 to 4% of individuals in the population had indeed a monoclonal protein. But what they did then was interesting. They took 3 different groups, one of which did a full workup for underlying disease. That was around 1,300 patients. They had a bone marrow performed as well as other staging labs. And 10% of those people turned out to have smoldering myeloma. This meant that 10% of people with a monoclonal protein who were otherwise healthy turned out to have smoldering myeloma when a bone marrow was performed. That meant the prevalence of smoldering myeloma in a totally healthy population was estimated to be 0.5% in individuals 40 years of age or older, and it was actually about twice as common in men. Now, based on this, and these are my own math, that means that half a percent of all people over age 40 have smoldering myeloma unrecognized, so 1 in 200. 1/3 of these had intermediate to high-risk smoldering myeloma, so 1 in 600. This would mean if we screened the population, the general healthy population, 0.17% would need treatment if you treated all smoldering myeloma. But if the only high risk was to be treated, that's 15% of the 0.5%, which means in the United States, 108,000 people are walking around with undiagnosed myeloma that if we decide to treat high-risk disease would need treatment today. So this would be a highly significant decision to start treating all high-risk myelomas if we were screening broadly for that. Now here's Bob Kyle's classic paper from the New England Journal showing the risk of progression of smoldering myeloma, indicating that there's a bit of a hockey stick curve to this, with most risk being in the first 5 years after a monoclonal protein and smoldering myeloma are first identified, with a 10% risk per year of getting myeloma in the first 5 years, that then drops to about 3% per year, and after 10 years drops to about 1%. I always like to point out, however, that this means that half of the patients with smoldering myeloma need no treatment for 5 years, and 25% of patients need no treatment after 15 years. So suggesting, again, we have to be very careful not to overtreat patients who really need no therapy for decades if it can be followed carefully. Which means we have to try and better identify who are in this first group in the blue bar here that progress very quickly, who are the high-risk patients. It's also important to note that there are some myeloma-defining events now which have now been concluded to indicate that a patient already has myeloma and should be treated immediately because the risk of getting active disease within the next 2 years is so high. Those include bone marrow plasmacytosis, over 60% of the marrow involved, and you'll see that by 2 years, almost 100% of those patients have active disease. The serum free light chain ratio over 100. And you'll see here at 2 years, about 75% of patients have already got myeloma, and the presence of a radiologic abnormality, the median time to get myeloma only being 13 months. So any one of these events now, if you find these in your workup for a smoldering patient, does suggest that they should be treated now. Now, the model that has become quite popular, and I think I like it myself because it's quite easy to remember, is this 2-20-20 model to identify high-risk smoldering myeloma patients. This stands for a monoclonal protein over 2, and you'll remember our patient initially had an N spike of 1.8, but it went up to 2.4 over time, so that would be score 1. More than a ratio of 20. Initially, our patient had a ratio of 18, but it went up to 34, so score 2. And she started with 25% bone marrow plasma cells and biopsies, so score 3. This would place our patient now in a high-risk smoldering myeloma group with a 44% chance of progression to active myeloma within 2 years. The intermediate risk group would have one of these features, and the low-risk group, which has almost no chance of progression in the next 2 years, would be the low-risk group. So I've actually mentally started using this myself. I find it the easiest of the different algorithms and numbers to remember when I'm in the clinical seeing a patient actively. Now, the Spanish have added to this cytogenetics. It's an imperfect study, but it does suggest that if you have any one of these high-risk cytogenetic features, the classic translocations of 414, 1416, gain of chromosome 1 or deletion of chromosome 13, we see that you can actually push the high-risk group into from about 40% progression at 2 years into about 60% progression at 2 years. And so I think, again, one could factor in a little bit mentally as to whether or not these high-risk features coexist with the 2-20-20 rule. I think another very important feature, and it's, I guess, to cut to the chase here, it's the one that I tend to practice in my own clinic, is actually watching for a while to see what the evolution pattern of the smoldering myeloma is. Now, this is a Mayo Clinic study where they looked at evolution over a year of monitoring. They monitored whether the monoclonal protein had gone up by at least 0.5, excuse me, or there was a 25% increase in the first 12 months, or that the hemoglobin had dropped by half a gram in the presence of bone marrow plasma cells had gone up to over 20%. And we see here again, if you have all three of those risk features, that the evolution of the disease is almost guaranteed to show you active myeloma very quickly within 1 year. So again, I think a very practical issue is that if you see this evolution happening at the bottom of the slide, you see here that with all three of these risk factors, 90% of patients go on to get myeloma very quickly, and they probably need treatment. Now, what's happening genomically? This is again from Dana-Farber, and it's just a graphical illustration to see that on the right of the slide here in this group. Just get the pointer here. This group here, we see these are the people who did not progress with a very low mutational burden. You see the patients with smoldering myeloma who did progress here, and you see that most of this is due to the acquisition of RAS mutations, which were not present at all in the non-progressors. A lot of them became present along with other mutations throughout the genome in those patients who progressed. So not surprisingly, I think we see that we begin to understand better that it's the acquisition of new mutations that might drive the acceleration of the disease. So the question then is to treat or not to treat. And this is, of course, a matter of quite a lot of controversy even today. We see the reasons for treatment might be to delay symptomatic progression, excuse me, to maintain or increase quality of life by treating early, and of course the elusive possibility of cure. Now, why would you not treat? Well, there's a lot of concern that especially using single agents will drive the selection of a resistant clone and cause more problems downstream, that none of these drugs are without some toxicity, particularly in this era of infection. But certainly second primary malignancies and deep venous thrombosis are other concerns. The cost of treatment, which is not insignificant, and the risk of overtreating those patients who may go 5, 10, or 15 years without requiring any therapy. Now, the outcomes that one might expect include, excuse me, here scenario 1, which early treatment completely eradicates disease and results in cure. Scenario 2, where early treatment eradicates the bulk of disease and the rest can be controlled over time with chronic disease management. Or scenario 3, where all you do is breed clonal resistance and cause aggressive clonal selection with negative downstream consequences. So these are the factors we have to think about as we move into thinking about how to treat this or not. Now, there have been two very large phase 3 clinical trials published using lenalidomide. The first was from Spain, shown here, which showed a very significant progression-free survival advantage, and I'll show you overall survival in the next slide, and a similar trial from the United States showing the same thing. So there's no doubt that lenalidomide applied to smoldering myeloma can result in the delay of progression to active disease. I think that is quite clear. However, if we look at the Spanish trial, there was quite a lot of criticism of the eligibility criteria for this trial, in that some patients with known lytic bone disease were included. The general sense might be that these should have been classified as myeloma at the beginning and treated, and it may explain why in this study there was an overall survival advantage to using lenalidomide in high-risk smoldering myeloma, but there was a little bit of concern from the non-trial investigators that perhaps some of the control arms should have actually been on active treatment. Now, the North American version of this, the ECOG trial run by Dr. Loniel and other people on the call here today, did show this progression-free survival advantage overall. It seemed to be true for all patients using the Mayo risk scores. And generally speaking, again, PFS, but not overall survival, was demonstrated. A couple of other points to make about this, however, on the next slide. The subgroup analysis demonstrated, however, that this benefit was completely restricted to the high-risk population. Intermediate risk or low-risk smoldering myeloma really had no impact on progression-free survival. And if you look at the bottom of the slide, 40% of patients had to discontinue lenalidomide due to adverse events. And second primary malignancies were 11% in the treated arm versus 3.5% in the control arm. Again, I think something that we have to pay a little bit more attention to and be cautious about. Now, these trials have led to a proliferation of more aggressive interventions. This one initially came from Ola Langren and his group that went quite early on to treat both newly diagnosed myeloma, but also 12 high-risk smoldering myeloma patients with a combination of carfilzomib, lenalidomide, and dexamethasone for 8 cycles, followed by lenalidomide maintenance. So here you'll see the overall response rate was 100% in smoldering myeloma. The vast majority of those were negative by flow cytometry, by MRD, but only 75% were negative by next generation sequencing. 100% of patients had were in remission 18 months later. So this was really quite encouraging, which led the Spanish and Dr. Mari V. Mateos to then produce, I think to date, or at least in published data, the most aggressive approach to high-risk smoldering myeloma yet, which was carfilzomib, lenalidomide, dexamethasone, a transplant, followed by consolidation, followed by maintenance. So essentially at this time, this would have been state-of-the-art therapy for myeloma itself. And again, the initial results were quite encouraging. We see very high response rates. But I'll draw your attention to the bottom of the slide here and note that the MRD negativity, despite this incredibly aggressive regimen, was only between 55 and 65% for the high-risk and ultra-high-risk patients. So despite 2 years of continuous therapy, we have essentially a third to almost half of the patients not in complete remission, not cured, suggesting that, again, that this isn't the answer for everybody. And certainly in verbal communications recently, Dr. Mateus has indicated that as treatment has stopped, these patients are relapsing. And so they were not cured by this very aggressive regimen. Again, I think drawing into question whether the benefits of early intervention outweigh the risks if people are not being cured. Bringing us up to speed, the Mayo Clinic group again have gone a step further. They're using KRD plus datatuzumab in the ASCENT clinical trial. Early days for this, just to say that so far the quadruplet regimen has been quite well tolerated, although we do see, of course, here in the green a lot of low-grade toxicity, some thromboembolic events, hypertension appearing as grade 3 or higher. And I always remember one of the first patients we put on the ECOG clinical trial was a young woman at Mayo Clinic who died of a pulmonary embolism on the smoldering treatment arm of lenalidomide. So this is not without some risk. So there's a long list. I won't go through all of these, of course, but there are a long list of clinical trial interventions in high-risk smoldering patients. There are even some attempts to look at high-risk MGUS patients with daratuzumab and other diseases, perhaps getting a bit ahead of ourselves, ahead of our skis, as they would say. But however, obviously a very active area of investigation. This is the trial that Dr. Gabriel and colleagues in Boston are running. It's similar to the Griffin trial myeloma you'll hear about in a minute, which is VRD plus daratuzumab, again in high-risk smoldering disease. So just to sort of summarize where we're at, for MGUS, I think we all continue to agree that close monitoring is all that is required. For smoldering myeloma, there are 2 options really. It's close monitoring for most. Perhaps if high risk, there is the possibility of using myeloma drugs that we can discuss. And I think many of us, if we see osteopenia, will also add a bone targeting agent to try and prevent increased risk of fracture, because that's been well documented to be an issue with not just with smoldering myeloma, but also with MGUS. So generally agreed upon that for low and intermediate risk smoldering myeloma, observation is still the logical course of action. Repeating labs, depending on the evolution of disease, every 3 to 6 months, and addressing new symptoms quickly if they appear. We show also that smoldering myeloma is not a single disease. It's obviously a spectrum of very likely to progress quickly versus very unlikely to progress quickly. And it's really a discussion between the patient and the provider as to which is what sort of risk tolerance both parties have. And with that, I think I'll close, and we'll turn ourselves back to the vignette and take your thoughts on this again. So just to remind you of the case, healthy, otherwise healthy, some sensory peripheral neuropathy leading to workup, anemia, mild anemia, normal counts, no crab features, IgG 2700, M-spike 1.8, serum free light chain of 18, So one of the two 2020 high-risk features, which was 25% plasma cells on the marrow. You waited 6 months. Now we see there's some evolution, and she now has 3 high-risk features of smoldering disease. And the question again is, what would you advise? A new bone marrow, repeat PET scan, 24-hour protein, lenalidomide, a possible referral for clinical trial. You would start DARA, Len, Dex because of long PFS, or you advise against any therapy since PFS is not improved by early intervention. We'll let you vote now. I would say there's not really a super wrong answer here. Many of them, there's still a lot of gray area in this question. I'm going to move now, if you've had a chance to vote, to the responses. Just give everybody a chance to see the votes coming in now. Okay, just give me 5 more seconds to vote. And the referral for a possible clinical trial at the local hospital, if interested, was actually how I would have voted too. I think just to run through the answers, I didn't think a new bone marrow would be any of it much value. We already know she has 25% plasma cells. It's true that the Spanish trial showed some increased overall survival, but there was some criticism of that, and the US trial has not reported that. Starting treatment now is quite popular. I think, in my mind at least, there are no clinical trials of this regimen in high-risk smoldering that have been presented yet, really, that have been shown PFS advantage, so I guess I would not have chosen that myself, but again, this is a kind of a grey area. So thank you, very interesting responses. I'll move it back to to Josh for the next presentation.
At this time, we'll turn it over to Dr. Gareth Morgan of Perlmutter Cancer Center at NYU. Dr. Morgan. Gareth, I think your camera and mic are on mute.
Good morning. Sorry about that false start. It's great to have heard Keith talk on smoldering myeloma. We're going to move over now to presenting cases of newly diagnosed myeloma. The vignette is a 55-year-old African-American working in a manual job who slipped at work and injured her pelvis, leading to an admission to the emergency department. She had a fractured pelvis through the head of her socket of her femur and was in severe pain and required pain relief and injection of cement to stabilize the disease. During the admission, a biopsy showed multiple lytic lesions and 85% plasma cells in the bone marrow. The M spike was pretty undramatic at 3 grams. The light chain ratio was normal, but she was anemic with a low platelet count at 40.4 and a white count of 7, and actually had some circulating blasts with a left shifted blood film. Despite that, her creatinine was normal and her cytogenetics showed deletion of 17p with a relatively normal beta 2 microglobulin. And the questions come up now, which is the patient is standard risk and will do well with treatment. The patient is high risk and should be treated with alkylating agents. The patient has plasma cell leukemia, and treatment should be aimed at achieving MRD status, or simply the patient should be treated with standard therapy. So you should cast your votes now, and we'll come back to the questions at the end of the presentation. So my job is to talk to you about multiple myeloma upfront therapy, and I have no relevant disclosures in the context of this presentation. So treatment has evolved over the last 20 years, and a number of agents have come and gone, but we really have 4 major types of therapy that are available that are useful in the upfront setting. The IMiD-based drugs, including Revlimid, thalidomide, and pomalidomide. The bortezomib-based, the proteasome inhibitors, which inhibit the proteasome, and the major agents are bortezomib and carfilzomib. And then more recently, we have a number of antibodies that are available that are either directed against the plasma cells as naked antibodies, or are used to deliver a target, either an ADC or a CAR, or a fix the T cells against the plasma cells. So kind of a really interesting and effective toolkit now. And the question is, how do you use those drugs in the clinic? And this is a study which I think is very relevant to the way we treat patients, in that at least 30%, 40% of people from presentation to first relapse, only 60% of people receive second-line treatment, and this percentage goes down at each line of therapy. And what I think this tells you is saving your best treatment until the third line of treatment means that 60 to 70% of patients will not get the best treatment. So as Dr. Fonseca likes to say, always put your best foot forward when it comes to treating newly diagnosed myeloma. Choose the best treatment and apply it in the front line setting, because that first progression-free survival period is likely to be the period associated with the best quality of life and to bring with it the best survival. And so for considering therapy, I think it's really important that we think about what we're trying to achieve and how we design and use the treatment. It's not adequate anymore just to pick a drug. I think personalization of therapy is becoming very important, and we should try to ameliorate symptoms. We should try and get the best responses. And to do that, we have to address the complex biology of the disease. So combinations are always likely to be best. But in the context of that, we have to select combinations that have minimal side effects. And personalizing the decision based on the patient and the disease is really important. But a guiding principle should be to maximize the response rate and the depth of response. And we should design combinations that overcome resistance, and then we can maintain responses. And in a sort of more forward-looking way, we should think about segmenting disease into different biological segments, such as high risk, where you might consider more intensive treatment, and specific cytogenetic subsets, such as the 11-14, where venetoclax may have a role. In spite of that sort of more forward-looking approach, on a very clinical level, I think we're all clinicians, we see patients in the clinic, and it's possible to recognize these different phenotypes. The younger transplant-eligible patient, where deep response and cure is the major aim. And in contrast to that, we have the very frail patient, where the selection of gentle treatment, preserving quality of life, is really important. We talk a lot about transplant eligible and transplant non-eligible, but these frail patients with comorbidities are really a clinical challenge about choosing the most appropriate treatment, but keeping in mind the principles that I laid out in the earlier slides. And so this has been the natural history of myeloma that people recognize, where you have what Keith eloquently described, the MGUS and smoldering myeloma cases becoming active myeloma, then multiple lines of treatment with this relapsing, remitting characteristic of the disease, with a lot of people having relapsed and refractory disease and needing special treatments, and we'll hear about that later. But in some way, I'd like to encourage you to think more of this as a natural history of the disease that we'd like to achieve, where at first-line treatment, you maximize the depth of response, introducing most people into a deep response, and then maintaining that response long-term, as this is the period where quality of life is best. Relapse will happen, but rather than waiting until people have clinical disease, I think there's a clinical imperative to intervene somewhat earlier than when people get significant end organ damage. And so the way to think of treatment, I believe, is as induction, consolidation, and maintenance. And for transplant-eligible patients, I think this involves induction, stem cell transplantation, and then to review the data for consolidation, whether we should use consolidation, what is the role of a second autologous stem cell transplant, the role of maintenance, and what is maintenance at this point in time? Is it a fixed dose, fixed duration period, or is it until progression? And so I kind of talked about this induction, transplant, consolidation, maintenance approach, and this is the iceberg analogy, where the amount of disease gets reduced over time, hopefully until there is no detectable disease. And this is one more graphical way of presenting that data, where the deeper the response, if you relapse at the same rate, the longer the progression-free survival. And what we're really trying to do is to get down to these levels where there's undetectable disease, where maybe you can control the disease long-term, and for a small proportion of patients, long-term survival is an achievable endpoint, even if this is only at low levels currently. And this is the data that I think provides a strong indication for why we should achieve that. And this is Nikhil, who will be talking later's meta-analysis to which we contributed kind of significant amounts of data showing that the cases that achieve MRD negativity not only stay free of disease longer, but also have an associated improvement in long-term survival. So there is a rationale for improving responses both pre and post-transplant and during the maintenance period. And 4-drug regimens seem to be the way to achieve this. And this slide shows a series of data over time, ranging from doublets to triplets, and then 4-drug regimens, showing that the depth of response is maximum with the use of these new 4-drug regimens, either Dara-RVD or Dara-KRD, which seem to achieve the maximum response rates. And these response rates are achieved both pre and post autologous stem cell transplant. And so this is a good clinical study which has raised a lot of excitement, comparing what was considered a standard before RVD to Dara-RVD, where Dara is added into the triplet combination at both pre-transplant as consolidation, post the transplant, and Revlimid versus Revlimid daratumumab during the maintenance phase. And this has given us a number of time points where we can look at the response rate. And the key to the figure is in the bottom left-hand corner, but each of these slightly darker colors represents pre-transplant, post-transplant, then post 24 months. And you can see that the CR rates go to really very significantly high levels in all of the Dara-RVD treated groups, the low risk and the high risk groups, which I find to be very compelling, and that translates into a progression-free survival that's quite significant. It's too soon to see an overall survival benefit. And when we look at cases that are MRD negative, in the cases that have become CR, there's a substantially higher and very impressive rate of MRD negativity, suggesting that this is a good, well-tolerated induction regimen. And interestingly, the introduction of daratumumab didn't increase the side effect profile. And so we've done induction and then MEL 200 autologous stem cell transplant. What is the evidence for that? And what are the outstanding clinical questions? So what should we do with high-risk cytogenetic abnormalities? And I'll show you something about that. Should we do a single or a double transplant? Is it possible to reserve the transplant until relapse? And what is the role of consolidation versus continuous treatment? And so this is the data from back in the day showing that stem cell transplant was better than the gold standard treatment. And this is a meta-analysis showing in the 3 studies that were carried out that the transplant did do better than standard treatment. This is the MLC 7 study showing transplant versus standard treatment. In this case, it was a combination of alkylating agents, ABCM. There was never really a survival benefit shown for any of the transplant studies, and certainly for the use of 140 mg per meter squared or lower doses, it was never shown that these were better than standard treatment. And so I think it's important to bear this in mind as we go forward with improving standard treatments and what is the role of reduced intensity stem cell transplants at doses other than 200 milligrams per meter squared. So this is the IFM 209 study, which compared RVD at a slightly prolonged dose compared to RVD plus stem cell transplant, with both arms having 1 year of maintenance with len. And interestingly, the number of responses significantly higher in the transplanted group, with 10% higher, and negative by flow cytometry even higher. So a significantly improved response rate and PFS rate. And again, this shows the kind of responses obtained with induction followed by transplant, where you get up to 80% greater than VGPRs in the post-transplant phase, which I think tends to suggest that stem cell transplant at this point in time remains a standard of care for younger, fitter patients able to tolerate it. And then comes the question of tandem stem cell transplants and whether we should be doing double autos. And I think there is much more indecision around this. And currently, I would say in the US, it is not a standard of care. But the IFM 94 study did show a significant divergence of the curves beyond 72 months in the group that had a double autologous stem cell transplant. And interestingly, this was not in the higher risk groups or the groups that achieved very good responses where there was no difference between the two arms. It tended to be in the group that were slow responders with slightly more indolent disease, where long-term the curves did separate. So that's where we are with double stem cell transplants in a standard risk groups. And then comes what is the role of maintenance. And there are two high-quality maintenance analyses, one involving ixazomib, where ixazomib maintenance did significantly better. It was active in all risk groups, but was not approved by the FDA because of a lack of a survival benefit. In contrast, len maintenance was approved by the FDA. There have been a number of studies, including an impressively sized meta-analysis. This is some data we generated from the UK showing again that len maintenance is active across all cytogenetics subgroups and risk groups, including high risk and ultra high risk patients. So I think I've painted a picture of induction, stem cell transplant, maintenance, and then we have to consider risk groups and cytogenetic segmentation of disease, and should we be doing some sort of personalization and risk stratification. So there's high risk, which mostly behave as standard risk and have reduced overall survival. Ultra high risk refers to something much more aggressive and resistant to treatment. And there's little data for this ultra high risk, but there's significant data for high risk patients, by which we mean del17p, 414 or 1416. And these are the frequency of those events. And so this is a meta-analysis from Neef Bergsagel showing that for high-risk patients, specifically those with the 414, if you get a proteasome inhibitor, you do better than the controls. And if you don't receive it, you do worse than controls, favoring the idea that proteasome inhibition is of significant benefit for patients with higher risk disease characterized by the 414. It is worth saying that if you look across the frontline daratumumab studies, that daratumumab is active in low and high risk disease, and so offers a significant therapy for patients with high risk disease. This is the EMN02 study, which compared double versus single autologous stem cell transplant. And in this study, at least for the del-17p 414 patients, there was a significant benefit for receiving the double versus the single autologous stem cell transplant. And overall, there is the difference. So that amounts to the best evidence for double versus single transplant. But this is a European study in which daratumumab was not available and RVD was not regularly used. The Stamina study, on the other hand, is a US study where stem cell transplant was used. Then they were randomized to either consolidation, no further treatment, or a tandem stem cell transplant. And while the initial studies showed no difference between the two arms, with longer follow-up and looking at the higher risk groups, it seemed that there was a potential benefit for the double transplanted group. Given where we are at this point in time, I still think it becomes a difficult decision to go for a double transplant in the context of the US, where for drug induction, consolidation, and maintenance is regularly used. And importantly, for higher risk disease, should we consider intensifying maintenance above and beyond what you can achieve with Revlimid alone, and a combination of carfilzomib plus Revlimid, I think, is of some interest, especially in patients with higher risk fish lesions, based on the Forte study from the Torino group, where you can see the improvement for the carfilzomib Revlimid treated group from the second randomization. So I think there is some relevance of considering what you do use in the clinic for maintenance. And I think there is a logic for post-transplant measuring the response of the disease, looking back to see what the cytogenetics are, defining the risk group of that patient, and then making an informed decision about where you want to go for maintenance and the duration of that maintenance. Moving away from the younger, fitter patient, I think we come to the kind of elderly patients where you range from the very fit to the severely frail. And it's important in this setting to take kind of wise clinical decisions based on comorbidities such as renal impairment, hemoglobin levels, quality of life, the ISS stage, and performance status. And I should say that high-risk cytogenetics has different implications in the elderly, where things like ISS and performance status are much more important in terms of determining risk. And this is some intuitive Italian approach to making decisions, where if you have no risk factors, you dose as normal. But if you have more than one risk factor, you really consider carefully the dose and the number of combinations that you might use. And so we should consider convenience, compliance, and the duration of the treatment. And again, a similar type of decision-making process can be made for the duration of treatment that you choose. And you should optimize the use of IMiD drugs in this population based on killing the tumor at diagnosis, whereas during the maintenance phase, the use of steroids may be counterintuitive as you use the immunomodulatory effects of the drugs. And the first study from the IFM group, again, compared continuous RD to RD for 18 months, compared to a very good historical standard in melphalan, prednisone, and thalidomide, and showed the importance of RD continuous in improving progression-free survival with not much of a overall survival benefit. But based on this, a standard became Revlimid and daratumumab, Revlimid and dexamethasone for the older, less fit patient. But this has been superseded, and I show you that study to define the control group and then the comparison to Dara-RD in the Maya study, where for the first time we really started to see significantly improved response rates with significant numbers of CRs and stringent CRs in the elderly population, with this significantly improved progression-free survival, which was seen in the kind of forest plot across all of the risk groups, suggesting that at least now Dara-RD is a standard treatment for older patients with newly diagnosed myeloma. But just to bring us back to the other standard, which I think still is a standard, is that when RD was compared to RVD in the SWOG study, in a slightly different group, that the RVD study did better than the RD for both PFS and OS. And again, there were more overall responses. So suggesting there are two standards that you can choose to use in the older group, RVD or R, Dara and Dex. And the choice of that depends on the patient. But you should also be aware that RVD light is the important way to go in the clinic, where Velcade is used subcutaneously weekly to avoid the peripheral neuropathy, which is a serious problem in the older age group. And at some level, the side effect profile of our Dara is better than RVD. So in conclusion, I think I've shown that we've made significant improvements in the outcome of patients with newly diagnosed myeloma using treatments that have sequentially improved the depth of response. While for the younger patients, transplant remains a standard, I think the next generation of studies using T-cell engaging therapies, which we'll hear more of later in this program, are likely to change this situation. Currently, response-adapted therapy in the clinic, adjusting the treatment based on response, is really a reality, and it's important to measure response accurately and regularly. I also show that in older patients, for the first time, it's now feasible to obtain deep responses and to maintain them long-term. So back to the vignette. This 55-year-old African-American worker who injured herself at work, sustaining a fractured pelvis with 85% plasma cells in the bone marrow, evidence of compromise of her blood counts, circulating blast, but no damage to her kidney, and a large clone containing 17p deleted cells. Which of the statements are correct? And so the patient is standard risk, the patient is high risk, should be treated with alkylating agents. The patient has plasma cell leukemia and treatment should be aimed at achieving M or D status, or the patient should be treated with standard therapy. So if you could cast your votes. And so the patient is clearly has features of high-risk disease, including the 17p minus and the packed marrow, which is with the low platelet count is going to make it very difficult to deliver treatment. The use of alkylating agents in patients with 17p minus probably not optimum because it impairs the apoptotic response to DNA cross-linking. And I think the correct answer is that the patient has plasma cell leukemia. It is very much ultra high risk based not only on the 17p minus and the packed marrow with impaired hemopoiesis. And we should try to achieve MRD status. Whether or not we'll be able to achieve that is difficult to be certain because delivering the treatment, I think, is going to be difficult for this lady. So thank you all for your attention, and I'll pass over to Josh to introduce the next speaker.
Thank you so much. It's my pleasure to pass it on to Dr. Saad Usmani to walk us through sequencing therapy in relapsed myeloma.
Thank you so much, Dr. Richter. It's a pleasure to be here and follow up on wonderful talks by my colleagues, Dr. Stewart and Morgan. And I'm going to carry on with the same theme because the field is evolving very quickly, and so we have to bear in mind some of those emerging paradigms and trends. I will pick things up from where Dr. Morgan left off. So, our frontline approach to transplant eligible patients is evolving. We're just starting to distinguish our frontline approach now for standard versus high-risk patients, specifically in the consolidation and maintenance settings. But the general approach we have, for standard risk patients at my center are the quadruplet dara-VRD based off of the Griffin study, and then once patients recover from their stem cell transplants, len maintenance. For high-risk patients, it could be a triplet or a quad. The impact of daratumumab in the schema of frontline treatment for high-risk patients, I'm still on the fence, even though it's trending that way. But either a quad or a triplet are reasonable choices there, but the maintenance is what has really made an important impact if you compare the data from the endurance trial, the SWAP 1211 study, as well as the Forte study, as well as the RVD 1000 experience from our Emory colleagues. The reason why I'm sharing this slide is to give you the context of how we are thinking about factoring or selecting treatments at relapse. Dr. Morgan also talked about the approach for transplant ineligible patients where we are employing RVD light as part of the induction therapy, and then after 8 to 12 cycles, when the response has plateaued, we move on to maintenance in those patients. And there again, for standard risk patients, the preference is to keep them on len maintenance until progression or intolerance. And PIMID maintenance strategies can be employed for high-risk patients. And then based on Maya, it's DRD that we start off with and continue with dose attenuations to the immunomodulatory drug in that combination. So, so this is the current treatment, approach in the frontline setting, which will help inform, the treatment choices at relapse. When we're thinking about selecting treatment choices, we think about patient-specific factors such as age, performance status, comorbidities, marrow reserve. Those all go into play. The pattern with which the disease is relapsing, whether it's a slow biochemical relapse in a standard versus high-risk patient, or is it a clinical relapse, rate of rise of disease burden, the amount of organ damage, presence of high-risk phenotypes like extramedullary disease or plasma cell leukemia, we may employ, more alkylator-based therapies to control that kind of disease early on in eligible patients before we consider that, the continuing therapy. And then, what kind of previous therapies were rendered to the patient? What was the depth and duration of response? The side effects, I think a lot of consideration now goes into logistic issues, especially if you're if the patient's living in an urban setting. How far is the cancer center, away from the patient? We have several oral options as well. So all of those things go into play as we think about, the various treatments. So if we were to look at that landscape of patients coming into that first relapse, they could have many different pathways. They could have had different exposures to that initial therapy, with or without stem cell transplant. And the time it takes from them to receiving that initial therapy, going into a response and relapsing, the period of relapse is also important as we're thinking about the options to pick for our patients. So let me walk through, some of the clinical trials. I think the first group of studies that I'm going to talk about are the lenalidomide dexamethasone combinations. These were the first group of studies, either combining a proteasome inhibitor like carfilzomib or ixazomib with Lendex and comparing it with Lendex, or an antibody-based therapy like elotuzumab targeting SLAMF7, or datatuzumab targeting anti-CD or CD38, combining with Lendex and compared to Lendex. So these were the first, one of the first, groups of 3 versus 2 drug combination studies in the relapse setting. At that moment in time, we were still, the only 2 classes we had were PIs and IMiDs, and there were a lot of thought around, sequencing by class switch. So, one thing that we find in these trials that's relevant to our current practice is the fact that low proportion of Len-exposed or refractory patients were included in this trial. And on the previous slide, I just shared with you that majority of our patients in the US practice are going to be Len-exposed or refractory because, we follow this continuous therapy model. Where patients are either on a Len maintenance alone or Len with a proteasome inhibitor if they have high risk disease. But if you do have that Len naive or Len exposed patient who hasn't been on Len before, I think amongst these studies, perhaps KRD and DRD are the ones that provide the best PFS benefit. And that benefit is conferred even in, Len-exposed patients in subgroup analyses. And typically those are the 2 preferred regimens. If we look at the same time frame, all of these, studies had excluded Len refractory patients. And the studies that included those patients were the CASTOR trial or the single-arm study, the MMI 1001 with dara-POMD. The ENDEAVOR trial included Len refractory patients, and that was a comparison of KD given, at 2056 milligram per meter squared twice weekly compared to bortezomib dexamethasone. And then the POMDEX versus dexamethasone phase 3 study. But if you look at, the top 3, you'll find something consistent in that Len refractory patient population. The median PFS was somewhere around, 8 to 10 months. So we had to, examine this patient population, in other clinical trials with other combinations. And the next generation drugs, pomalidomide and carfilzomib, would be, the optimal choices, if we're thinking about the various next potential combinations. So let's take a look at the pomalidomide dexamethasone-based options that we have for this patient population. There were several trials looking at anti-CD38 or SLAMF7 monoclonal antibodies being combined with Pomdex. The Apollo trial looked at subcutaneous daratumumab with Pomdex, comparing it to Pomdex. Icaria looked at isatuximab, which is the other anti-CD38 monoclonal antibody, combined with Pomdex. Elotuzumab was combined with Pomdex in the Eloquent 3 study. The first two were randomized phase 3s. This particular one was a randomized phase 2 study, but enriched for that Len refractory patient population. Optimism trial, looked at the combination of pomalidomide dexamethasone with bortezomib compared to the two-drug combination. What you see across the board with each of these combinations, is a similar kind of a PFS, even though the prior number of regimens is a bit different and the populations may be a bit different. For the top three, I think, the fact that they were enriched for Len refractory patients is important. And what you're getting is about 10 to 12 months of PFS benefit. However, if we look at the carfilzomib-based combinations, this is where, we're seeing more of a benefit for that kind of patient population. So whether it's combining the anti-CD38 daratumumab or isatuximab with carfilzomib and dexamethasone, the PFS benefit, is quite impressive for the Len refractory subset population. Here, I also want to mention the carfilzomib combination with cyclophosphamide dexamethasone. And this was a study that was done by the Spanish myeloma colleagues that kind of flies under the radar many times, but I do want to highlight this, combination, because this study also included, about a third Len refractory patients, and appears to give, a reasonable PFS for patients who are Len refractory. So just something to consider. All these three are potentially good options for that Len refractory patient population. Specifically in that first line of treatment, for patients who are Len refractory, and relapsing in that first line of treatment, for the overall population, we're seeing a very high overall response rate and MRD negativity rate, and that also translates to the Len refractory patients in this subgroup. If we look at the International Myeloma Working Group guidelines, treatment at that first relapse is really delineated. The treatment tree or options are really, separated based on refractoriness to lenalidomide or not. So here we see for Len, patients who are not Len refractory, DRD or KRD as the preferred choice. And yes, you do have other options that you can potentially try, but many of us, most of us would actually reach for those as the preferred option. For the patients who are refractory to lenalidomide, the preferred options would be, the anti-CD38 carfilzomib dexamethasone combinations, but then you do have other alternates. And again, you're paying attention to the patient population that went into each of those randomized studies as you're trying to pick, the next option. So what about the subsequent relapses? According to the IMWG guidelines, any first relapse option that has not been used, preferences for at least 2 new drugs, triplets are preferred. But again, many times, we end up enrolling those patients on clinical trials. I do want to add the paying attention to availability of stem cells, if they were collected for patients, and utilizing them at the time of relapse if transplant was not performed as part of the frontline treatment, or there was durable remission from that first autologous stem cell transplant. That's something that one can certainly consider, in this patient population. The way that we think about relapse options at MSK is very similar to the IMWG guidelines. We pay attention to prior LEN or PI exposure and refractoriness, and pick our treatment options accordingly. Here, the only distinction is if we do have a LEN and PI refractory patient, this can happen, especially in high-risk scenarios, then an anti-CD38 pomalidomide dexamethasone-based combination, may be a reasonable choice. If you have someone, who is relapsing off of both LEN and DARA and they're PI sensitive, then KPD or KSID or POM-VD may be potential options. And we also, always think about an autologous stem cell transplant. As patients get to that next relapse, majority of those patients are going to be LEN and bortezomib refractory. So here, we're really thinking about whether patients have had either CAR or POM exposure and which of those drugs they're sensitive to. This is where, we think about using elotuzumab with POM-dex or POM-Cy-dex, especially for patients who are CAR and DARA refractory, but still POM sensitive. And then, if patients are still CAR sensitive, then KPD or KSID would be utilized. And here, we have been able to get venetoclax dexamethasone with or without a proteasome inhibitor for our translocation 11-14 patients, beyond that, second relapse. So, I think that the challenge for us, here in the U.S. right now is, that venetoclax is still off-label, and it's still difficult to get it in the earlier lines of treatment. And perhaps this is something that we can potentially discuss, when we get to the Q&A discussion portion, because we do have several novel therapies that are coming down the pike that will change the landscape of how we're treating patients in the relapse setting, even in the first and second relapses. So we have, small molecules, exportin 1 inhibitor, selinexor combinations, are making their way. We have the CELMoDs, or I guess the grandchildren of thalidomide analogs, iberdomide and CC480, that are that have shown single agent promise and now being combined with other mechanisms of actions. And I think our first biomarker driven therapy, venetoclax, it's being combined with other mechanisms of actions, and this will likely be something that we would preferentially use for translocation 11-14 patients. And then, belantamab mafodotin, or belamaf, which is an anti-BCMA antibody drug conjugate, or BCMA-directed antibody drug conjugate, it's now being used in combinations. And, we'll hear, a lot more depth about bispecifics and CAR-Ts, from, in the next talk. But I do want to, share some of this data to kind of put things in context, because all of these options will likely make it into earlier lines of treatment, and our algorithms will likely change. So selinexor dexamethasone was originally approved, through a single-arm phase 2 on an accelerated approval track. In fact, Dr. Richter's center, I think, enrolled a fourth of the global patient population. And this original study showed an overall response rate of 26-odd%. Selinexor was given twice weekly, and the big issue with this approach was the tolerability, with this approval. But then, there was a proof of concept study that kind of was linked to that original accelerated approval called the Boston trial, that combined selinexor with bortezomib and dexamethasone, showing that, giving once weekly lower doses of selinexor, can lead to this synergy with the proteasome inhibitor combination. I do feel that, the carfilzomib combination will likely be utilized more commonly. in clinical practice. In fact, many of us, are able to utilize carfilzomib with selinexor, dexamethasone in that late relapse patient population that is truly triple class refractory, while we're trying to, search for clinical trial options, for our patients. I think this is probably where, we'll see selinexor being utilized more. It's not going to be in the earlier lines, but probably in the later lines of treatment. The CELMoD iberdomide, the original single-arm study, along with or without dexamethasone, was led by my colleague, Dr. Loniel, showing, good clinical activity in about almost a third of the patients, and these were PI mid-data refractory patients. And the study has moved on now to combinations with datatuzumab as well as bortezomib. And what we're seeing in that early safety profile is, primarily, hematologic and GI-like side effects that you would see similar to IMiDs, but you're not seeing an incidence of thrombotic events. So no, pulmonary embolisms or DVTs reported in either the daratuzumab-based combination or bortezomib-based combinations. And we're seeing very high response rates in heavily exposed patients. So, if you look at that, daratuzumab-based combination cohort, 27 patients in the dara cohort, 26 of them were IMiD refractory, 15 were dara refractory, 13 were triple class refractory, and we're seeing a response rate of about 42%. Similar kind of pattern we're seeing with that bortezomib, combination experience. So I'm looking forward to, more data and seeing, how iberdomide moves, into the scheme of myeloma treatment. The next CELMoD is CC480, which is specifically designed for more rapid protein degradation, and it's showing, early clinical promise as well. So data presented by my colleague, Dr. Richardson, 2 years ago at ASCO, the single agent activity in all evaluable patients was 21%. This was a dose escalation study. At the recommended phase 2 dose, that the activity goes up to about 54.5%. With some deep responses. So this is making its way into the clinical trials and combinations, and something that we will be paying attention to. I had already mentioned, venetoclax, which is an oral BCL2 inhibitor. Not just as a single agent, it appears to be active with proteasome inhibition, so bortezomib combinations. We already know about the Bellini trial, which was a randomized phase 3 study, which was halted initially because there was an increased number of deaths in the venetoclax arm of the study, but that was relevant to the non-11-14 patients. If we look at the 11-14 subgroup specifically, that's where that clinical benefit in Bellini was coming from. So we're hopeful that venetoclax continues to make its way in clinical trials. There are several combinations being examined with proteasome inhibitors like carfilzomib, and we also now have data with daratuzumab, specifically showing good activity in the 11-14 patients. Belantamab mafodotin, I just want to mention this as an option that we have for our triple class refractory patients. This is a BCMA-directed antibody drug conjugate. The key issue with this is ocular toxicities, which is currently being worked out in clinical trials with dosing and schedule modifications, and it's now being combined with other mechanisms of actions, including IMiDs, and proteasome inhibitors. So more data to come. We actually saw some data at ASH. So, and in fact, Dr. Susan Trudell combined Bela in lower doses and less frequent schedule with pomalidomide and dexamethasone, showing good activity. The bispecific antibodies are a very busy space. So bispecific antibodies have the ability to recognize a surface antigen, in this case BCMA, as well as CD3 on the T cells, and those patient T cells do the cell kill, showing very good clinical activity in triple-class refractory patients. We'll hear more about the BCMA-directed CAR-Ts from in the next talk, but I think both of these strategies will likely change the way that we're approaching myeloma treatment, even in the early relapse space. And, before, I kind of end my talk, I do want to highlight this particular option. One of the things that we're trying to do with this next generation slew of CAR-T trials is to see if we can shorten the duration of the production time, which is, a big challenge for the earlier products. Here we have an allogenic anti-BCMA CAR-T cell therapy, which is showing good early promise with an overall response rate of about 60 odd, percent in the higher, in the overall patient population. And if we get to, the higher dosing, it's, approaching 65 to 70%, without, high grade CRS. So more things to come. I think there is going to be, a lot of room for each of these therapies. There are frontline CAR-T trials that I think, my colleague, Dr. Munshi will highlight. And, as we think about all these various options in relapsed myeloma, immunotherapies are super exciting. They give us a disease biology agnostic modality. I think the small molecule combinations will help individualize approaches, and the sequencing will continue to evolve, as we gather more data on the pattern of relapses in the era of frontline treatments with anti-CD38 monoclonal antibodies. So with that being said, I'd like to acknowledge my team and thank you all for listening. I believe we do have a clinical vignette, and this is more of a discussion and walking you through a specific case here. So we have a 64-year-old Caucasian man who presented to his primary care physician with increasing back pain, which was not improving with conservative measures. X-ray of the lumbar spine showed numerous lytic lesions. He was found to be anemic and had acute renal insufficiency, which was different from about 12 months ago. His serum protein was normal, but serum calcium was elevated, albumin was low, beta-2 microglobulin was elevated. SPEP only showed lambda light chains on immunofixation, and his lambda light chains were elevated with an abnormal involved to uninvolved ratio. He gets a bone marrow biopsy showing 45% plasma cells with lambda light chain restriction. His FISH is positive for translocation 414 in 35% of the cells. PET shows multiple lytic lesions throughout the axial skeleton and vertebrae. 3 FDG avid lesions were seen. SUV max was 9.1. He gets diagnosed with revised ISS stage 3 disease with IgG kappa myeloma. So this is a real case, but predates our current treatment approach. So let's see what happens to this patient. So the patient goes on, receives RVD as induction, gets into a VGPR, gets a stem cell transplant, and then is on len-only maintenance. And then after 18 months of len maintenance, he's developing some superficial skin cancers. There's some data that was reported about, the possibility of second malignancies. He's concerned, even though he's reassured that superficial skin cancers, really, come from sun exposure, but he stops. Now he gets, he presents again with disease relapsing. 2 years later, he gets restage, and his FISH, is also showing deletion 17p in addition to translocation 414. So this is someone, who is, len exposed, but interestingly for translocation 414, Despite the fact that he had been off of therapy for 2 years, he's done reasonably well for that first PFS benefit. So since it's been a while since he had len exposure, he got started on KRD as the next line of treatment, has a good response. He had stem cells left over, but decided not to go through a stem cell transplant. And he got treatment for 19 months, and he's progressing again. So now he is len and PI, refractory, but he has not received datatuzumab. So that ends up being that next line of treatment. So he gets datatuzumab with pomalidomide and dexamethasone. He gets VGPR as best response. He received this for 16 cycles, and now he's having both a clinical and biochemical relapse. So, he's got pain in his left clavicle and scapula, gets local XRT, and so, what would be the next step? This patient ended up enrolling in a clinical trial. He is now triple class refractory, approaching his 4th line of treatment, and he gets enrolled on a BCMA CAR-T, and he's in a stringent CR, currently 20 months out. So I believe this was my last slide. Dr. Richter, I can hand things back to you, and maybe we can use this vignette when we get to the post-program discussion. Thank you so much.
So before we, first of all, thank you so much, Dr. Usmani, for an extremely comprehensive talk. Before we hand it over to Dr. Munshi, I would like to remind those tuning in to please submit your questions, any questions relating to myeloma, any of the topics presented, to the Q&A box, which is located on your screen. Following the presentations, we will address any and all questions submitted through the Q&A. And with that, I'd like to pass it over to Dr. Nikhil Munshi. Nikhil? Nikhil, I'm not sure if you're on mute or your camera's off as well.
I'm not on mute.
Oh, there you are.
Can you hear me?
Yes, sir. The floor is yours.
Okay. Thank you so much, Dr. Richter. And it's my pleasure being here in this wonderful discussion so far, starting from smoldering, newly diagnosed, and then Dr. Usmani comprehensively discussing the general landscape of treatment option. Now I'm going to focus on the immune-based treatment, and before that I'll go with one of the case clinical vignettes about an interesting case that sort of sets the stage of where some of the CAR-T treatment may or may not be used. So this is a 74-year-old gentleman who had coronary artery disease, mild diabetes, and hypertension, and he presented with pain, rib pain, mainly fatigue, and initially mild anemia. His workup later on showed presence of IgA kappa paraprotein with an M spike of 4.9 and a kappa and lambda light chain 91 and 3.3 with a ratio of 32.4. The bone marrow showed 80% plasma cells, cytogenetics normal, but fish showed 414 translocation. Patient had anemia, hemoglobin 8.1, calcium 9.1, creatinine slightly elevated at 1.5, and a PET CT revealed vertebral compression fractures and rib lesions. Serum albumin was 3.2, microglobulin 8.1, LDH 125. Now the patient received initial treatment with RVD light. He's 74-year-old. He achieved a PR, but did develop neuropathy, and then he received a maintenance lenalidomide for almost 1.5 years. He relapsed on that and was switched to datatuzumab and pomalidomide with dex, achieving a PR for 12 months. And then he relapsed, and he was switched over to carfilzomib, cytox, and dex combination. He only received achieved a minor response, lasted for 3 months, and then progressed. Over the 3 years period, his reasonably close cardiology follow-up showed that his cardiac function were relatively stable with his ejection fraction of 50. And so the question I have for our audience is that which of the following treatment options are not available to this patient at this stage? 1, selinexor in combination with bortezomib and dexamethasone. Number 2 is DCEP, which is a standard chemotherapeutic regimen, very active in aggressive disease. The third one is a CAR-T approach with ide-cells or cilta-cell-like regimen. And number 4 is elotuzumab with pomalidomide and dexamethasone. So please answer, but we will go to this, the case and its discussion at the end of my presentation. And so I would switch over now to discussing about BCMA as a therapeutic target and what does the CAR-T cell therapy mean and where are we going with it. My conflicts. So BCMA is a very good target in myeloma, especially for immunologically targeted therapies or approaches. And the reason is multiple. So number one, as you see on the right side, it's predominantly expressed on myeloma cells, on normal plasma cells, but no other cells. None of the hematopoietic cells, other hematopoietic cells express BCMA. So specific expression only on the tumor cells and a very small component of hematopoietic cells. Number two, as you see on the left side, it's an important molecule that is involved in cell signaling. So by binding to BAFF and APRIL, various signaling pathways are activated that keeps myeloma cells functional and growing. And that dependency on BCMA for cell growth makes it a good target without which myeloma cells may not survive as well. Not entirely true in practical sense, but that's what we could conclude. And the third interesting component is that there is a molecule called gamma secretase, which in a normal setting cleaves the BCMA, leads to release of BCMA in the circulation, which we can measure as a soluble BCMA molecule. And there is significance to it both in regards to what the disease means, also significance to it in regards to how we can make the CAR-T or BCMA targeted treatment better. So first about how the soluble BCMA help us in the disease management. We know that the level of soluble BCMA increases from normal cases, which is 37.9, to MGUS, smoldering myeloma, and then to active newly diagnosed myeloma. Very big difference as we go along the chain of this disease spectrum. Number two, the soluble BCMA predicts outcome. The levels are connected with both event-free and overall survival, with higher level suggesting lower PFS and lower overall survival. So it's a good prognostic marker, also might be reflective of the disease burden. And finally, and which is very important for what we may do in future, is that the soluble BCMA trends with the M spike, which is our traditional myeloma marker. So these are 4 different cases, and you could see that the M spike measured in red and the soluble BCMA measured in blue, they really track with each other quite reproducibly, suggesting that if we measure one or the other, we can gauge the tumor burden, the response, etc., very well. So keeping those things in mind, what we can conclude is that soluble BCMA is related with the disease stage. It changes with the disease burden. It's a good tumor marker, and that may allow us to measure myeloma burden and the treatment response in patients who are oligosecretory or non-secretory. As we all know, that's a very important factor that we face in a number of patients, especially in a late stage of the disease in some cases. Its connection with prognosis is important, and very importantly, its level is independent of renal function, so we can measure it reproducibly even in those patients who are on dialysis and or has a significant myeloma-related renal changes. And finally, it can affect immune status in the patient, can lead to immunodeficiency, and so monitoring it may give us some idea about patient's immune function. So soluble BCMA by itself is a very important target and a measurement that is going to impact how we manage myeloma in future. Now, if you go to targeting BCMA, and my focus is going to be targeting BCMA with CAR T cells, and my colleague, Dr. Richter, is going to discuss about BCMA in regards to bispecifics and the ADCs. And if you look at CAR T cells, it's a therapy where we modify the T cells by introducing a group of genes to provide spatial function. Now, the spatial function that is imparted on the T cell includes a cell surface expression of an antibody-like molecule, the scFv, which leads myeloma cells binding to those CAR T cells, leading to myeloma cell death induced by the lymphocytes. Number two, it contains two components, which leads to activation of T cells. So when we inject myeloma cells and the myeloma cells bind, we inject CAR T cell and myeloma cells bind to those CAR T cells, the T cells proliferate and increase in number, providing greater strength to increase number of myeloma cell killing. And so the three components that goes into the CAR design are the anti-BCMA scFv in green, the 4-1BB, which is the co-stimulatory molecule, which provides the co-stimulation for T cells to kill the myeloma cells effectively, and finally CD3-zeta, which leads to myeloma cell proliferation. And for my colleagues who are in the audience who have probably treated lymphoma patients or have had lymphoma patients who have been treated with CAR T cells, the process is very similar here. The first, we collect patients' white blood cells, then they are genetically modified and activated, and then introduction of the sequence through usually the viral vector and expansion of the cells. And this process takes 4 to 5 weeks. And this is a long enough time that we may have, in many cases, hold the patient's disease by giving something called bridging therapy, just for short term, 4 to 5 weeks. After 5 weeks, the cells are frozen, delivered to our centers where CAR T cells can be given, and then patients following lymphodepletion, which is usually given by fludarabine and cytoxan, patients get CAR T cell infusion. So this is the process, and this is the biology of how the cells are produced. Now, there are two main important CAR T products. Both have been now approved for utilization in patients with multiple myeloma as a fifth-line therapy, those patients who have received 4 lines of therapy. That is the main important point to keep in mind for this therapy, that it's for limited patient population. Now, I'll go through very quickly the data from this study. They're well published, both of them. So this KARMA study was with ide-cel. It was for relapsed refractory myeloma patients. The CAR construct is very similar to what I showed you just earlier. This was for relapsed refractory patients with 3 or more prior lines of treatment and exposure to immunomodulatory drug, proteasome inhibitor, and an anti-CD38 monoclonal antibody. The therapeutic algorithm is very similar as I described. First, there is leukapheresis, CAR production in this study, 99% success rate in CAR T cell production. If necessary, bridging therapy in this study, 88% patients required it, so patients were very aggressive and fast progressing. Lymphodepletion, CAR T infusion, and first assessment of the response and subsequent follow-up. 128 patients have been treated on this study. The target and eventual therapeutic dose for this product is 450 million cells, but it included 2 other dose levels. Now, the patients who were treated in this study and also similarly in the next study with cilta-cel are very advanced disease. So median line of treatment has been 6. Median years from diagnosis, 6. Patients with prior transplant, 94%. And if you look at refractoriness, refractory to anti-CD38 antibody, 94%. Majority of them also refractory to bortezomib and lenalidomide. So in this very advanced patient population, overall response was 73%. At the target dose of 450 million, the overall response rate was 81%, with close to 40% patients achieving CR or stringent CR. Now, this study also shows that progression-free survival in this patient population is significantly increased to 8.8 months. In a population like these patients here, what is expected is 2 to 3 months. At the target dose of 450 million cells, the PFS was 12 months. Overall survival, you could see, is 19.4 months, and patients have had a good quality of life. As in this study, there was no maintenance after CAR T-cell infusion, so they were not on any treatment during the time of follow-up. The second product that is approved is cilta-cel. This is a molecule with similar ideas in the construct, except the binding domains on the surface are two. So there's dual binding of the CAR to the myeloma cells, and that probably increases the avidity, and as you will see, subsequently probably the responses. Now, the schema is very similar to what I described for KarMMa: 3 lines, 3 drug exposure, and resistance. And patients get same lymphodepleting therapy. Now, overall, 97 patients have received the cilta-cel infusion. The dose here is calculated a little bit differently, but it's a standard dose with 0.71 to 0.95 times 10 to the power 6 CAR positive cells per kg. Again, patients had 6 prior lines of treatment, 6 years from the transplant, 90% with autologous transplant, 75% requiring bridging therapy, and 99% exposed to and refractory to anti-CD38 antibody, and 87% were triple refractory. And if you see this patient population, the overall response rate is 98%, with 82.5% patients achieving a stringent CR, and 95% achieving a VGPR. If we look at the patient populations for PFS, the 2-year PFS, the median has not been reached. The 2-year PFS is 71%, and you could see that patients has continued responses. In some of them are sustained remission. If you look at overall survival, again, median has not been reached yet, but 2-year overall survival is 74%. And the update that was recently presented shows a 2-year OS of 74%. So sustained deep responses are observed with this specific type of treatment. Now, if you look at toxicities, both the CAR products have toxicities, but in general, CAR T-cell treatments in myeloma are relatively well tolerated compared to lymphoma. Everybody almost gets CRS, cytokine release syndrome, 95% in cilta-cel, 84% in ide-cel. However, grade 3 and 4 are very small, 5% in cilta-cel, 4% in ide-cel. So very low frequency of high-grade CRS observed here. The difference in this product is the time to CRS. Cilta-cel, median time is 7 days. Ide-cel, median time is 1 day. One is very quick, the other one is less. The neurotoxicity generally is similar between the two groups, 17% for cilta-cel, 18% for ide-cels, and other toxicities like infections are very similar. One important toxicity to keep in mind is the delayed neurotoxicity, around 9% in cilta-cel, not observed in ide-cel. However, there have been some mitigating measures instituted, which is now curtailing any development of delayed neurotoxicity, although we are continuing to observe it quite closely over time. And so these are the main toxicities observed with this type of treatment. Now, if we compare this current spectrum, there are many different CAR T-cell treatments being investigated. The cilta-cel and ide-cel I just mentioned. However, CRB 402, which utilizes BB21217, where the CAR T-cells are produced in presence of an anti-PI3K inhibitor to increase the population of memory T-cells. There is CT015, the BCMA 101 study, and there is a study with dual CAR that combines BCMA and CD19. And a common theme here is that all the patients are very advanced with median 6 lines of treatment, and we see a very high overall response rate, anywhere from 65 to 95%, with significant CRs, low-grade CRS, and limited neurotoxicity. And so there has been great excitement for CAR T cells, and we are lucky to have 2 products available to be prescribed to our patients, although supply still remains a little bit limited and one may have to wait. Few vignettes about this treatment. In a subgroup analysis with KARMA, similar results with ide-cel, one sees that various subgroups, high risk and others, have very similar responses with CAR T cells. So if you look at patients with or without extramedullary disease, with or without high-grade cytogenetics, high or low tumor burden, with and without needing bridging therapy, and patients with multiple lines of treatment, all have a very similar response with ide-cel. The only difference observed was in patients who are RIS stage 3, the response is there, but less than those who are not IRS 3, they're 1 or 2. So we have to keep that in mind as we consider patients. Now, another important point is that the CAR T-cell treatment can be given to all patients. The age is not exclusion criteria. Unlike transplant, where 70 and beyond, we usually hesitate. Here, we and others have treated patients at 80 and above quite safely. And what I'm showing here is that if you look at the outcomes of the patients who are less than 65 or 65 and greater, 70 and greater, responses are very similar. And the toxicity on the right side also is very similar between the two groups. So the tolerability is good, the responses are good. So this is an excellent treatment that can be utilized in patients who are otherwise not transplant eligible. Now, one more point that we should look at, how does it compare to the real world evidence? And similar studies have been done both with KARMA study and with cilta-cel study. And you see here that when patients with KARMA were compared with real world patients with similar characteristics, eligible relapsed/refractory patients, and the details are given here, you see that for real world, the PFS is so much different, so much shorter, ends up being closer to 3 years compared to KARMA study, where PFS for those patients is 12 years and greater. Similar differences are also observed in overall survival. So CAR T cells provides deep, durable responses that impact survival of this patient population. Now, it's important to keep in mind that how we collect the cells, how the cells expand. Just to give a summary view of both the products with showing similar characteristics, that patients' copy numbers of the cells significantly expands, and that's observed in patients who respond compared to those who do not. We don't know what is the cause and the effect, but that is a requirement or something frequently observed. Durability of response is also directly related with the exposure to the CAR T, how long it remains, and the level of it. And then the type of CAR T are expanding and effective. They are effector memory in observed and reported in ide-cel, but they are a little bit higher component of the memory cells, central memory cells in cilta-cel. More studies are ongoing to understand what this means and can we change the product to fit some of this requirement to get a better response and better effectiveness. One of the cases that we presented earlier is very instructional for our future algorithms about what we do, how do we do treatments after CAR T cells. So this was a patient who got a CAR T cell once, had a very good response, VGPR, relapsed, got a second CAR T cell, which had no impact. And when we looked at what happened in this patient, the first time CAR T cell expanded tremendously. Second time, CAR T cell did not expand. So we studied why patient relapsed and no response to the second CAR T cell infusion. What we observed was that there was really no difference in patients' bone marrow, the microenvironment, the CAR T cell were infused. They were very similar. However, when we studied patients' myeloma cells, we realized that patient had a high soluble BCMA at diagnosis when patient went in on the study. But at the time of relapse here, there was no increase in soluble BCMA. Like patients' myeloma cells were not producing soluble BCMA. And when we did further detailed study in this patient, we found out that patient had a biallelic loss of BCMA locus. Patient's myeloma cell had lost BCMA, both the copies. And so there was no BCMA, no response to second infusion. This is a very infrequent phenomenon, but observing it has made us now look for this and other factors when we treat the patients and they relapse from this type of treatment to decide what we do next. Now, just a very brief summary on plans of how to improve and what's ongoing about improvement in CAR T cells. There are improvements being considered for changing the product, making more effective cells. Also, having an allogeneic product, so we don't have to wait for CAR T cells being produced. We can just give it out of almost a bottle, or develop a method to make CAR T cell very quickly. And I'll show you very quickly, show you the data. There are various different the types of CAR T cell being investigated, the NK CAR T cell, but also other cellular products like gamma delta T cells, iNK T cells. So that's on one side. We can increase the target expression by using gamma secretase inhibitors, and then patient selection is going to be very important, especially can we treat patients earlier on and can we get better responses? And then can we combine CAR T cell with other treatment, checkpoint inhibitors, immunomodulatory drugs, to make them effective on one hand, and also develop sort of a maintenance strategy so when we get deep response, we can sustain it so we can go to a curative outcome. So one of the presentation by my colleague, Dr. Sperling, at this year ASH was this PHE885 treatment, where CAR T cells are now produced in less than 2 days, so very quick CAR T cell production. In the early presentation of the phase 1 study, the overall response rate has been 93%, with a response at the target dose is 100%. The kinetics of CAR progression is very predictable, with around 12 days of peak expansion. And we can see here in this, maybe a little bit too small for you to see, but we do see expansion of significant number of memory type CAR T cells, so they can persist longer and have continued impact. So the CAR might themselves function as a maintenance strategy. And this is one of the important components of this study. And what we have observed in this study is that the responses are very heartening. The study is ongoing. The second very interesting study is this gamma secretase inhibitor. As I showed earlier, gamma secretase cleaves the BCMA, and which is released in the circulation. If we use inhibitor, then the gamma secretase won't work. The BCMA won't be cleaved. There'll be many more BCMA on the cell surface, and we may have a better killing with CAR T cells. So that's an ongoing study, different doses of gamma secretase inhibitor with CAR T being infused. And what this study at the early stage shows, that using the inhibitor, there is a significant increase in BCMA expression on the cell surface. The red is before the inhibitors are given. The green bars are the levels on the cell surface after gamma secretase inhibitors are given. So significant increase. We see very high response rate, including responses in those patients who had previous BCMA targeted therapy. You can see 4 patients are here in this setting. CRS is not significantly high. The only number I would keep in mind for future is there any change in neurotoxicity? The neurological changes from baseline were 66%, higher than what we are used to seeing. However, some of them were at very low level, and a more comprehensive analysis will tell us that if there is any concern and we need to do any different dosaging, etc. And finally, allogeneic CAR T cells are important. This is where T cells are genetically modified to remove certain things, to remove CD52, so we can use the lymphodepletion by giving anti-CD52 antibodies or treatments. There is removal of the T cell receptor, so there is no allogeneic response. And then the CAR itself, the CAR construct is added similar to the other products I suggested. So now these cells are produced in large quantity, and then they are stored. So when patients needs it, the bag is shipped immediately. Patient can get treatment in next 3 to 5 days. So no waiting time, no bridging therapy needed. And using this, initial studies have shown a very good response rate in this patient population. The overall response rate here, you see, is 71%. In a second phase of the study, the response rate is being close to 70%. And the toxicities have not been significantly different than what we are used to seeing in myeloma. So this is an interesting, exciting start. More studies are needed to look at the longevity of the response, etc. But allogeneic CAR T cells do provide anti-tumor efficacy. And so we will wait and see what the results are. And the final slide I have is that can it be given in earlier stage. This CAR-T2 study investigated patients with myeloma following 1 in 3 prior lines of treatment. You see overall 95% response rate and stringent CR and CR in 70% of the patients. This is an early stage of the study, small patient population. That I would predict that the responses would deepen and it will only get better. Critical element would be to see the long-term maintenance of responses in this patient population. So to conclude, CAR T cell therapy are incredibly effective and achieving impressive responses. Now we have to select patients properly, and various these scenarios are under investigations. And our main task now is to sustain and maintain these great responses, which would then lead to curative outcome in this disease. And one of the pathways would be to understand the resistance mechanisms. So with this, if I would conclude my presentation, and we'll go back to the case again, just to remind everyone, 74-year-old gentleman, classic multiple myeloma. He has received the first-line treatment with RVD light, 8 cycles, 1.5-year response. Second-line treatment was with datatuzumab, pomalidomide, dexamethasone. And the third-line treatment is carfilzomib, cyclophosphamide, and dexamethasone. And now we are here for his fourth-line treatment. These are the options. Which one of the following treatment options are not available at this stage? So we're selecting what's not available for these patients. I don't have a music to play right now while you vote, but I would urge you to vote and see what your response would be. Dr. Richter is resourceful. That's all I can say. That's wonderful. So let's see if we have, okay. So 56% patients said CAR T-cell, and that's the right answer. And the reason is we all believe, and I think I'm speaking for all my colleagues on the podium here, that CAR T-cell needs to be used earlier on, not as a fifth-line treatment, but that's the current label for this treatment. And so in the fourth line, although medically it is the right decision to consider CAR T, it's not commercially available. The few of the vignette of this patient, one is the age. Patient is 74, 75-year-old, but I have no concern about this patient getting CAR T cells. Number two, patient had cardiac illnesses, not a major problem. In the cases of transplant, we need 50% ejection fraction. In CAR T cell, we don't have any number. A good stable cardiac condition is good enough for one to carefully treat the patients. Renal disease is not a major issue as well. And so this patient is a good patient to get CAR T cell, except he is currently not eligible. He will need to get one more line of treatment. And the three other answers are three possibilities which are approved for patients who have had a 4 or less line of treatment. Selinexor initially was for fifth line, but now with the combination with bortezomib and dex can be used in the earlier line of treatment. DCF does not require. It's a very effective treatment. Usually we give it to patients who have more aggressive disease, who needs a quick response, extramedullary disease, plasma cell leukemia. It's a very good choice in many cases. And elotuzumab pom-dex similarly is a good combination that can be utilized in this patient. So before we consider CAR T-cell in patients, in this patient, we have to use one of these options. So that's my summary. And it will be now my pleasure to introduce my colleague and our chair for this symposium, Dr. Richter, to take it away to the most important next part of the treatment, which is bispecifics and antibody drug conjugates. Joshua?
Thank you so much. Yes, hilarious that I'm chair when I'm the most junior of everyone on here. I think it's just because I'm able to pull up YouTube clips of Jeopardy theme songs very quickly. So let's go on to the fifth vignette. We have an 83-year-old female with IgA lambda myeloma, presents to her local oncologist, having multiply relapsed disease. She is an ECOG of 2. She weighs 98 pounds, has a medical history of hypertension and high cholesterol. Her prior therapy is as follows. She receives initial therapy with VRD light, bortezomib, lenalidomide, and dexamethasone. At the time of relapse, she goes on to Dara-Revdex, then goes on to Kyprolis, dexamethasone, and as a fourth line, isatuximab, pomalidomide, and dexamethasone. Based on the current FDA approvals, which of the following therapies is the best next option? Abecma, which is ide-cel, belantamab mafodotin, Carvykti, which is cilta-cel, selinexor, or teclistamab. And we're going to save the results of this for the end. But we're going to move on to the bispecific antibodies and antibody drug conjugates for myeloma. Here are my conflicts. And, you know, we've really had a tremendous change in the gestalt that we approach myeloma. You know, we've moved beyond the classical chemotherapeutic age where we were given things like VAD or oral Alkeran as standards of care. We then moved on to the novel therapies, the immunomodulatory drugs and proteasome inhibitors. And, you know, it's kind of bridging the gap between the novel therapies and the modern day immunotherapy approach, drugs like daratumumab and isatuximab, the CD38 monoclonal antibodies. But what we now understand is that there is a litany of targets that we can exploit that are expressed on malignant plasma cells and few other things, and we're able to specifically target these to maximize efficacy and minimize toxicity. And there are a large number of targets. Now, optimally, we are seeking a target that is expressed almost solely on plasma cells and ideally more heavily expressed on malignant plasma cells. And in many scenarios, we're trying to find targets that are not otherwise expressed on other tissues, even including other hematopoietic tissues. As we note that although CD38 targeting with drugs like daratumumab and isatuximab are extremely efficacious, CD38 is widely expressed on a variety of hematopoietic tissue. And I think we all remember this when we have our patients cycle into Dara-Revdex or Dara-Pomdex and they become neutropenic. But there are a variety of other targets that are being looked into. Some of them are more heavily studied and are further along than others. Obviously, the BCMA targets have had several approvals, with further approvals coming later on this year, but targeting a variety of lesser-known targets, things like GPRC5D, FCRH5, as well as a number of others, including assets that are targeting things as simple as the kappa light chain. Now, we have the ability to go beyond just targeting the malignant cell for destruction. And although that is a key approach, targeting myeloma cells based on their antigenic expression, we can employ other co-stimulatory agents and other targets to restore host immune surveillance. There are a variety of vaccine strategies that are currently under investigation, and then seeking ways to combine all of these, to combine immunologic cell death, to combine enhanced T cell activity or NK cell activity. So really the whole idea is not just to find single agents, but to find rational combinations to optimize outcomes and potentially cure for some, if not all, patients. Now, BCMA has been an extremely hot topic over the last few years in terms of targeting myeloma. Now, as opposed to things like SLAM-F7 or CD38, which use naked antibodies, we have no real naked antibodies under active investigation targeting BCMA and myeloma. The three approaches that are currently utilized are antibody drug conjugates, bispecific antibodies, and CAR T cells, as was just expertly discussed by Dr. Munshi. Now, the antibody drug conjugates are essentially a way of delivering a classical chemotherapeutic-like approach, but instead of delivering systemic intravenous classical chemo, we can add it as a payload, target cells expressing BCMA, and directly deliver the toxin to the malignant cells. Now, there are a number of these that are in active clinical study. Obviously, belantamab mafodotin is already FDA approved. Unfortunately, MEDI228 is no longer being pursued in multiple myeloma, but was a very active drug in the setting. And the Celgene compound 99712 is also continuing to be evaluated. The CAR T therapies, as Dr. Munshi pointed out, there are a large number of them and are seeking to target BCMA, both from an autologous standpoint and an allogeneic standpoint, with now 2 FDA-approved in the United States, idacaptogene viclucil and ciltacabtagene autoleucel, both FDA-approved and available, although, again, at the moment, slots are limited across the U.S. due to production issues. The hope is by the fourth quarter of this year or first quarter next year, much of this will be overcome and it will be more widely available. And to me, what is one of the most interesting approaches in relapsed refractory myeloma is the bispecific antibodies. These are drugs that you may have heard of in other diseases like blinatumomab, which is a CD3/CD19 bispecific for ALL, which engages the malignant T cell with cell with one arm and engages the T cell using CD3 in the other arm. In the realm of myeloma, we have quite a large number of these. And although the top one on the list, AMG 420, is unfortunately no longer being pursued in myeloma, quite a large number of these are in active clinical trial, with the second from the bottom, a drug which now goes by the name teclistamab, has already been filed for FDA approval, and we're expecting, fingers crossed, approval likely around August of this year. So how do we compare and contrast the three different modalities? So far, the CAR-T has a number of pros. It's a, quote, one and done. Whereas what is expertly explained by Dr. Morgan earlier in today's program, stemming from studies such as the first trial, we've demonstrated that continuous therapy shows improvement over fixed duration. Many of our patients, especially in the relapsed refractory setting, continue on therapy until progression or intolerance. The benefit of a CAR-T may be a one and done to provide patients not only large progression-free survival, but large treatment-free intervals. The cons of that right now, it's only provided in a limited number of centers with a limited number of slots and does have a significant toxicity, which is still being worked out. Bispecific antibodies are off the shelf, which makes it quite uniquely available for people with progressive disease that need therapy immediately. However, as CAR-T manufacturing improves and that production time gets less and less, we may have a similar thing in CAR-T, especially with the potential for allogeneic CAR-T. These are nicely combinable. We'll talk about some of the ongoing studies that have combined novel therapies along with the bispecific antibodies. And the reality is, in the US, 60 to 80% of myeloma is treated in the community. And CAR-T cells in any form will never be available for the community. However, with proper risk stratification, step-up dosing, and mitigation strategies, bispecifics could be provided in the community to provide them to a wider group of patients. Antibody drug conjugates, so far we only have one FDA-approved, belantamab mafodotin, which single agent in heavily refractory patients does show a response rate of 30%, which is somewhat lower than the CAR-Ts and bispecifics in similar patient populations. However, a variety of other studies have shown higher response rates earlier on in combinations. There is no CRS associated with this, so there is still a role for these therapies in patients who have not yet had a BCMA targeting agent. Now, the bispecific antibodies are a huge area of active research, and for the most part, we group them into two categories: the BCMA target bispecifics and the non-BCMA targeted bispecifics. Now, BCMA targeted, there are quite a few, and as I mentioned, teclistamab has already been filed for FDA approval, and what's the next step beyond this are the two other non-BCMA targets, including talquetamab and cevostamab. So far, the most mature data for bispecifics in myeloma comes from the teclistamab and studies like the Majestic-1 study. And here we see the single agent results of the BCMA CD3 bispecific of teclistamab, which identified the recommended phase 2 dose. And we see here, and these are patients who had a significant number of prior lines of therapy, a median of 5. And remember that a median of 5 prior lines of therapy in 2022 is far different from what that was only 5 or 10 years ago. You know, there was a time where people were getting sequential doublets, and 5 lines meant Revdex, Pomdex, Veldex, Cardex, and Daradex. Now, with studies such as Griffin giving Dara RVD up front, a 5th line plus myeloma patient has had far more exposure to other agents. And we see recent approvals in the myeloma space in 5 prior lines, having an average response rate of around 30%. If you look from daratuzumab, single agent, pomalidomide, carfilzomib, selinexor, belantamab, and melflufen, all of them were FDA approved with an overall response rate of between 25 and 30%. But here we see the single agent overall response rate of teclistamab as 62%. Now, although patients did experience CRS and neurotox, the majority of this was grade 1 and 2 and quite manageable. And again, the fact that this is a therapy that we give over time in multiple doses, we have less concern about giving aggressive CRS preventative therapy, because even if we destroy that T cell response on cycle 1, day 1, we get another shot at cycle 1, day 8 to hit them again. Another drug that has come far away is the TeneoBio asset that was recently acquired by AbbVie, and this has been presented by some of our colleagues at the Mayo Clinic, Shaji Kumar, presenting this data. Now, again, the TNB383, now ABBV383, is another BCMA CD3 bispecific that engages the malignant plasma cell as well as the attacking T cell. Now, one of the benefits of this asset is the dosing schedule. Some of the current bispecifics, especially the BCMAs, are dosed either weekly or every other week. One of the advantages of this asset is the Q3-week dosing. And we see here again, at a median of 5 prior lines of therapy, the overall response rate when given at a dose of greater than or equal to 40 milligrams is 81%. And across the board, we're seeing response rates of around 60 to 80% in extremely heavily pretreated myeloma patients with single-agent BCMA bispecifics. So really, the sky's the limit, especially as Dr. Munshi had mentioned. We're looking towards things like the CARTITUDE-2 study. And if we see extremely potent responses in the end-stage patient, we can only begin to imagine what improvements we may see in earlier lines of therapy with CAR-T. The same is true for the bispecifics, both BCMA and non-BCMA. And here again, with the Kaplan-Meier curves being extremely impressive, with an estimated 12-month PFS of 72%, again, these are patients where if you look at the Flatiron data for pentarefractory patients, the Flatiron data suggests that pentarefractory patients have a median overall survival, not progression-free, but a median overall survival of around 5.6 months. So we're about to enter a new age in managing heavily refractory patients with very effective therapy. Now, BCMA, even though the BCMA story has yet to be completely written, we're already looking beyond this. So much as the CD38 and pentarefractory patients were looking at BCMA therapies, we want to be mindful that BCMA therapies to date are not curative. So we must now focus on, well, what do we do for those who are BCMA refractory? And one of the key areas of investigation has been the G protein coupled receptor family C, or GPRC5D target, which we see in the bispecific talquetamab, which was presented by Amrita Krishnan of City of Hope. And again, this is a GPRC5D CD3 bispecific. Again, this has been an extremely potent drug, studied here from the Monumental study, which identified the recommended phase 2 dose as dosing of 405 micrograms per kilogram. Note also here that this is subcutaneous administration. So one of the things that we're seeing with a lot of the BCMA bispecifics to improve quality of life is sub-Q route of administration for patients who need to remain on chronic therapy. Now we see here with patients with median of 5 prior lines, overall response rates of 66 to 70%. And again, CRS rates were fairly high in the mid-70s. However, the majority of this is grade 1 and grade 2. One of the things to note is that GPRC5D is expressed on other tissue besides malignant plasma cells. And one of the potential side effects that are seen in clinic are things like rashes, including a desquamating rash on the hands, not too dissimilar from what we used to see with Xeloda a number of years ago. And also due to the expression in the aerodigestive tract, we have patients with significant dysgeusia, which needs to be appropriately managed. Now, another target beyond GPRC is the FcRH5 target, and this was specifically studied in the cevostamab study with the FcRH5 CD3 bispecific, which was recently presented by Suzanne Trudel from Dr. Stewart's neighborhood. And again, the bispecific here engages the Fc receptor homolog 5 on the malignant plasma cell, along with the T cell to engender anti-tumor activity. Now, this data is a little bit farther behind the GPRC5D talquetamab data, but now that we are getting closer to our effective doses, we do see a 36% overall response rate in all comers, but when we get to the higher dose levels now, we see an overall response rate of 56%. Again, this is intravenous at this time, not yet subcutaneous. We are giving it Q3 weeks. One of the issues across bispecifics is step-up dosing. We recognize that giving full dose on cycle 1, day 1 may lead to unacceptable levels of CRS and neurotox, and one of the ways to mitigate that is to either do a single or double step-up dosing. And across a variety of these assets, it's still being ironed out what the best way to do this is to either give one step-up dosing on cycle 1, day 1 and full drug on cycle 1, day 8, or two step-up dosing, so a low dose on cycle 1, day 1, a mid-range dose on cycle 1, day 8, and full cohort dosing on cycle 1, day 15. Recognize that for the majority of these assets, hospitalization is still required for between 24 and 72 hours for the first few doses to help monitor and treat any evidence of CRS or neurotoxicity. And again, even in heavily pretreated patients, so far the data here is showing median duration of response of almost a year, which is extremely impressive in these heavily refractory groups of patients. Now, the way that a lot of myeloma therapies go through their journey in post-approval is they start off as single agent at the end of the road, and we slowly move them further and further up the line and combine them with previously established active agents. The same here is already true for talquetamab and teclistamab, and here we see some early results of the TRIM protocol combining talquetamab, the GPRC5D bispecific, along with daratumumab. Now, there is a rationale. It's not just combining one good drug A with another good drug B. This is really focusing on T-cell expansion and enhancing T-cell cytotoxicity between the CD38 target and the GPRC5D target. Now, so far in the TRIM2 protocol, and this is with patients with a median of 6 prior lines of therapy, we're seeing extremely impressive and so far quite durable responses. So again, very early data. The median follow-up is only 4.2 months, but the time to response is only a month. The overall response rates have been north of 80%, and this may be one of the standard approaches in early relapse in the not-too-distant future. We are following correlative work with this to ensure that what we're truly seeing here is not only synergy, but that we're actually seeing T-cell activation through chemokine and cytokine increase, as well as T-cell proliferation. And we recognize that as we have more and more assets in myeloma, because there's simply not enough bandwidth to study every single combination, the goal is really to provide rational combinations and rational studies to get to the best answer as quickly as possible. Now, with the advent of CAR-Ts FDA approved and bispecifics will likely be approved in the third quarter of this year, the question is, we will end up in a space where we have both at our hands. And does it matter how we sequence them? CART or BITE, BITE or CART? Or is it once you give a T-cell redirecting therapy, that's it, you need to go to another modality? This is a slide that was presented by Dr. Van Eckelen from our group this past IMW meeting. And what he did was compared patients who got CAR-T or bispecific, and then what they got as their next line of therapy. And despite whatever they got, CAR-T or bispecific, the people who performed the best got another T-cell redirecting therapy afterward. So we, I think, used to have, or at least I used to have the thought that once you progress off of a T-cell redirection, be it CAR-T or bispecific, that's it. You've exhausted your T-cells. You need to move on to a different modality. But what is really coming to light is that you can sequence these therapies, and in a time where we're going to have multiple targets, BCMA, GPRC5D, and FcRH5, we recognize that these are independently expressed on plasma cells, so we may be able to sequence different modalities and different targets as we go from relapse to relapse in our myeloma patients. And what I like to say is the immunotherapy quadrifecta, we actually have a patient at our institution who has received quite a large number of therapies, and the most four recent in sequence were talquetamab, BCMA-targeted CAR-T, teclistamab plus daratumumab, and now cevostamab. And we actually can have patients where right now our first few lines of therapy are usually things like VRD, Darapom, and Case ID. There may be a time in the not-too-distant future where patients' first few lines of therapy are all immune-based and can be sequenced and lead to potentially, hopefully, even better responses. Now, switching gears, we go to the BCMA antibody-drug conjugates. And so far to date, there's only been one approved, belantamab mafodotin. Now, again, the MEDI228 AstraZeneca asset is no longer being pursued in multiple myeloma. It's a very interesting drug, but unfortunately suffered from similar toxicities to belantamab with ocular toxicity. Now, GSK has a variety of studies ongoing combining belantamab with other drugs in their DREAM series of studies, DREAM 1, 2, 3, and so on. Now, what ultimately led to the FDA approval were the results of the DREAM 2 study, originally presented by Dr. Sargalonial. And we see here that these are patients who had relapsed refractory disease after at least 4 prior therapies, including an anti-CD38, a proteasome inhibitor, and an IMiD. The drug is given at a dose of 2.5 mg per kg intravenously once every 3 weeks as a 30-minute infusion. Now, the patients here were, again, standard patients, kind of across the board. Nothing particular about them except they were refractory to the majority of therapies that we currently use in earlier relapse. And what we saw here is an overall response rate around 30%. And one of these things was interesting that in the DREAM 1 study, we saw a response rate that was closer to 60%. When we finally flushed it out in the phase 2, it dropped to 30%. And I think one of the things that we've all seen is that it's probably actually a little bit higher than this in clinical practice. And even patients who have to stop will have a significant benefit from the drug. As you see here, a median duration of response of 11 months, even though the median PFS is only 2.8 months. Now, what has been the difficulty with the drug is the ocular toxicity. The drug was approved with a REMS program requiring an ophthalmologic or optometric evaluation within 1 week prior to every dose of the drug. So far, mitigation strategies for the ocular toxicity, which is keratopathy, have mostly been for dose holds and extension of the interval of treatment. So going from every 3 weeks to every 4 to 6 weeks, and even every 8-week dosing if need be. Lubricating eye drops do help. So far, some of the studies about steroid eye drops have not really shown significant benefit. There's some interesting studies ongoing looking at other immunosuppressive eye drops like cyclosporin, but too early data to comment. Now, the DREAM protocols have involved a variety of other combinations, including the DREAM 6 study combining bortezomib and belantamab mafodotin, which has been presented by Popad as well as Ajay Nuka. And we see response rates here of 78% when given in combination with bortezomib and dexamethasone in an earlier setting. So again, combinations are quite exciting. And at this most recent ASH, we saw Dr. Trudell present the Algonquin data combining belantamab with pomalidomide and dexamethasone. And although the overall response rate here of 88% in all comers and in dual refractory patients 92%, this was extremely encouraging. The notion that more than 3/4 of patients experienced keratopathy does give us some reason for pause. Again, the majority of this is grade 1 and grade 2, and it does appear to be reversible by simply holding the drug. This drug really does require the appropriate patient choice to optimize not just outcomes, but to minimize toxicity. So in conclusion, we really kind of evolved in our myeloma approach on the whole. We really started off with classical chemotherapy in the days of melphalan, cyclophosphamide, and the DCEPs. And these drugs still hold a role in our therapy. But for the most part, if you look at our first and second line for the majority of patients, we're in the realm of novel agents, IMiDs and PIs, and now datatuzumab becoming part of upfront therapy and early relapse. But we're really on the cusp of moving into the new era of antibody-drug conjugates, bispecific antibodies, and CAR-T therapies. We have a litany of targets. And right now, we only have chronologic data to support order. So CD38 comes before BCMA or was approved before, so we use BCMA before CD38. Well, is that the best order? Would you do better if you gave BCMA before a CD38? What about GPRC5D and FCRH5? Ongoing studies will answer this. And there is the capacity for sequencing, noting that you don't necessarily exhaust T cells and you can give a bispecific after a CAR-T or vice versa, or even sequential bispecifics. Now, again, the average patient is not going to be the Lance Armstrong type of cancer patient. We have fit and frail, old and young, community and academic. And the reality is that although CAR-Ts are probably for the moment for the fitter patients in academia, we're going to have antibody-drug conjugates and bispecifics that can be given to older and frailer patients in the community, providing immunotherapy options for all. And with that, I will thank you. I will move on to the vignette. And while you're looking at the vignette, please submit any questions to the Q&A. We have some that were previously submitted, but any others, please don't hesitate. And moving on to the pretest vignette, here's our 83-year-old female with IgA lambda myeloma, presents to a local oncologist with multiply relapsed disease. She's an ECOG-2. She weighs 98 pounds. She has high blood pressure and high cholesterol. She originally received VRD light, and at the time of relapse went on to Dara-Rev-Dex. Then relapse went on to the KD, kyprolis and dexamethasone doublet, and has now been on isatuximab, pomalidomide, and dex, and is progressing. Based on the current FDA approvals, which of the following is the best next option? So we see here we have the Abecma or ide-cel, CAR-T cell, belantamab mafodotin, the antibody-drug conjugate, cilta-cel or Carvykti, the other approved CAR-T, selinexor-based therapy, or teclistamab, the BCMA CD3 bispecific. Oops.
That is,
and we'll
that is the music.
Oh, sorry, I'll get the music up. So let's see what answers we have. So, all right. So, I think what I was really trying to go for this was the patient is a little bit on the older and frailer side. She weighs 98 pounds, is an ECOG-2. This is a patient for whom Abecma and Carvykti, although excellent options on the whole, may be a little bit difficult in terms of toxicity for an 80-year-old who's an ECOG-2. Selinexor is an excellent drug, although because of the potential for weight loss, I do have concerns in patients who are relatively underweight, giving them selinexor. Teclistamab is an excellent drug, however, not FDA approved. And I think at the moment, this is the type of patient who is a great patient for belantamab, which is the majority of the answers that we got, because, again, this is an off-the-shelf product. Apart from the ocular toxicity, is well tolerated. Doesn't have any issues with CRS or ICON, so that was really the purpose of this one. And we're going to go on to some questions from the participants, which I have a few that have been sent in, but anyone else who has them, please send them through. And I would ask all of our colleagues who are currently on to turn on your cameras and mics so I can throw some questions at you. I think one of the first questions I want to throw back at Dr. Usmani. I want to find his slide. because I think he posed a really great clinical vignette, and I want to see if I can find the slide. Hopefully I can find the slide to ask him how he would have treated the patient, because I think it's a really great question to ask. Having a little trouble pushing it. Oh, there we go. Right.
Josh, is that the 64-year-old patient that I presented?
Yeah, so here's it. I was able to get it up here. So, Saad, I would really love to hear your thoughts on how you would approach a patient like this who gets RVD, transplant, rev maintenance, then stops, gets KRD and Darapom, because I think this is a patient that the community is going to be seeing quite a bit of.
All right. So is the question that if we were to see this patient today, how we would approach it from the get-go?
Yeah, I think how would we yeah, exactly. How would you approach this patient who is progressing beyond Darapom?
Okay, all right. So excellent question. So knowing that this patient is now PI IMiD data refractory, and given that he is getting close to the age of 70 or 71, he's still young. I think I had mentioned in the case that he had stem cells left over, and so I would actually, I offered it to this patient during the, this is a real patient. So as part of second line and as third line, and that's something that I would, discuss with him in terms of, trying to, as standard of care, what I would offer to him if he were to pick an auto, I would have given him maybe, carfilzomib with cyclophosphamide and dexamethasone as induction, and then followed that up with an auto. So that is the, Arkansas standard of care, melphalan loving Saad Usmani in me. But if he, if the patient would say, I don't care about, high dose melphalan and I want something new, then, I'd like to enroll him on a clinical trial with either a BCMA bispecific or a CAR-T. If that's not available, then, I would consider giving him belantamab mafodotin. The way that I would do this, because right now, it's hard to get patients, to commercial CAR-T. You can potentially give, Bela in patients, and you'll know within 2 cycles whether it's working or not, or whether they're having eye side effects or not. So that would be my approach. I'd welcome thoughts from you as well as other colleagues.
So Saad, I would, and I'm also Arkansas loving, melphalan loving person. I think melphalan, after everything else, is an extremely effective drug, despite everything else we do. And because if the CAR-T option was available, that would definitely be my next choice. But this is third line, so we need one more line. And I think melphalan would provide, in many cases like this, I totally agree with your viewpoint that it would be in consideration. Not that transplant has to be done, but I think it's a good choice. If not, we have to give something that will bridge the fourth line and take to the CAR-T next one.
And I would throw to the group a question that just came up in the chat box, which is, let's say you were able to get this patient a CAR-T, and I welcome anyone to tackle this. What are you doing now for a patient like this who is relapsing post-CAR-T therapy?
I think this is
where
I
can maybe take us. I mean, obviously, if in this is a tough situation, but I think one of the non-BCMA bites would be best if a clinical trial could be found for covestamab or talquetamab. Otherwise, he's in some pretty deep trouble.
Yeah, I couldn't agree more. And even post CAR-T, I share the love of melphalan, and the wonders here is that giving a patient like this high dose melphalan, you're not going to buy them years, but you may buy them enough time to get a couple of these drugs FDA approved, or convert them from someone who's not transplant eligible to transplant, someone who's not trial eligible to someone who is trial eligible. So I couldn't agree more that I think transplant now in this day and age, given the wealth of assets in clinical trials could be a great bridge. On the setting of CAR T, Nikhil, I would love to hear your thoughts, because I think a lot of the people listening are community-based docs, and I think as CAR T becomes more widespread, they're going to come to center like all of ours for a CAR T and then go back to the community for long-term management. Any thoughts or tips in terms of long-term strategies post-CAR T, either infection prevention or anything that you would recommend to the community doctors when we send CAR T patients back to them?
I think you brought a very, very important point, because I think we, similar to auto transplant, might do the CAR T ourselves at our place, but within 28 days, and in many cases, I would presume sooner, they will be back to their primary care physician or primary care oncologist for management. And I think that's where they're going to face a lot of important aspects of the post-CAR T complications and management. So one is related with side effects, and you very rightly pointed out it could be infection management. They need to be on prophylaxis. They might be cytopenic, so any fevers would need to be taken care of very, very carefully. They would need antiviral prophylaxis, and also require some growth factor support if the counts are very low, which quite happens to be the case in these patients. And again, very important final component for prevention would be that they would be very likely hypogammaglobulinemic, and they would benefit from getting IVIGs depending upon what their levels are, because BCMA treatments also get rid of normal plasma cell, which might take time to recover. So I think that is one component that everybody will need to look at. Number two, they need to look at later toxicity, the recurrence of cytopenia, very importantly, any neurotoxicity that we still have to keep an eye on, the delayed neurotoxicity, etc. And then few of the infectious complications which may come in separately. We had patients who develop CMV retinitis, CMV infection later on, and they need to keep and be conversant of those kind of complications that happen. And separately, without belaboring the point, I think we're all coming up with some maintenance strategy, and nothing I should suggest today, but stay tuned for utilizing maintenance strategy, which may be immunomodulated drug, PD-1, PD-L1 inhibitors, and similar such immune modulation that may come about for maintenance and or post-CAR T relapse treatments.
Phenomenal. Keith, I'd like to ask a question, because I think you and I probably view smoldering myeloma similarly, which is, I think that unless you truly, truly need therapy, not to give anything. My question to you is, apart from the clear myeloma-defining events, are there any features of smoldering myeloma, be it circulating plasma cell, light chain levels, that to you would either consider treating or you watch so intently because you think they're really going to need therapy in the next short period of time?
Well, once or twice in my career I've been burned by people going into renal failure during smoldering myeloma because we weren't watching the urine protein. So if there's urinary protein of any moderate to substantial amount, then I am more inclined to start treatment. I think obviously the other complications, amyloidosis, Poem syndrome, the sort of other rare renal events that happen would justify therapy, whether or not it's smoldering or active. I have a patient in my practice right now that I'm struggling with actually. It's quite bad peripheral neuropathy, but otherwise would have no indication to treat her smoldering myeloma. And I find that one quite difficult actually, because she wants treatment to get rid of her neuropathy. I'm like, well, we could treat it and it might not make any difference to your myeloma in the long run. So that's a difficult case. I'm very much against single agent therapy for smoldering myeloma. I think it's just inherently irrational biologically. It's just going to breed resistance. So I hold out as long as possible before treating. And I'm more interested in the evolution of the disease over time. So if I see the proteins going up, I always tell patients, the train's coming, we can see the lights. It depends how far away it is before we decide on treatment.
Brilliant. I couldn't agree more. And one final question I'll throw to Gareth, to you. We still in 2022 talk about upfront myeloma as being transplant eligible or transplant ineligible. what are your thoughts? Are in 10 years, are we still going to be having that conversation, or are we going to be done with transplant, or are we going to be able to select out those who really should get it? Just curious about your thoughts.
I think it's the most fascinating question currently is the promise of the CAR-Ts and bispecifics with the depth of response in that relapse refractory setting are out with anything we'd see with high-dose melphalan in that setting, I believe. And so my anticipation is that if those are used up front, that we'll see durable progression-free survival and possibly cure in a substantial number of patients, in which case autologous stem cell transplant will no longer have a role. A note of caution, though, the physician in me says, I think we have to do the clinical trials, and it is now a legitimate time to do a clinical trial of CAR-T bispecific versus autologous stem cell transplant. And we await those studies with interest, I think.
Agreed. I welcome any final thoughts from any of our colleagues of any last bit on this topic or any others that you'd like to bring out. Well, with that, we just want to mention to those tuning in order to obtain your CME continuing education certificate, please, you have attended the webinar completely if you're still with us. You'll be given a brief evaluation and a link to download your certificate at the end of this. And with that, I would extremely like to thank all of those colleagues who took time on their weekend to speak tonight. Dr. Keith Stewart of Princess Margaret, Dr. Gareth Morgan of NYU Langone, Dr. Nikhil Munshi of the Dana-Farber, and Dr. Saad Usmani of Memorial Sloan Cancer Center. Big thank you to our sponsor, Amgen and CancerNet and On24 for providing the very user-friendly platform. And with that, I would like to thank everyone for tuning in and wish you all a very lovely rest of your weekend.